Hello and a very good evening to all our viewers. I hope you all are doing well. Welcome to this new episode, wherein we are going to talk about thyroid function test interpretations in pregnancy. For this, we have a very special guest on board. Please welcome Dr. Zaineb Sabri, who's an internal medicine specialist at Medcare hospitals and medical centers in UAE. Now, health checkups are crucial for a normal pregnancy. Thyroid hormone status is a vital parameter frequently assessed during pregnancy for evaluating suspected thyroid abnormalities and monitoring pre existing thyroid diseases. Normally, pregnancy leads to changes in thyroid function tests, including transient suppression of thyroid-stimulating hormone, stimulation of thyroid androgen, and an increase in total T4 and T3 levels. So, assessing these changes and accurately interpreting thyroid function tests is a vital aspect to avoid thyroid autoimmunity and other adverse pregnancy outcomes. So, we would now welcome Dr. Zaineb Sabri for this lecture. She is a highly skilled specialist in treating diabetes, hypertension, metabolic syndrome, and thyroid disorders. She's also a member of Iraqi Doctor Medical Association and the Royal College of Physicians. Dr. Sabri counsels and educates patients about healthy lifestyle practices and also conducts annual checkups, women's health checkups, and suggests preventive vaccines and manages and assesses inpatient requirements. Besides this, Dr. Sabri is also an academic tutor at the College of Medicine, University of Sharjah in UAE. So without any further ado, let's begin today's session. Over to you, ma'am.
Good evening. I'm Dr. Zaineb Sabri, specialist in internal medicine. I'm from Sharjah Medcare Hospital in the United Arab Emirates. I have a subspecialty also in diabetes and endocrine. And I would like to thank Dr. Plex on their invitation for me today to present this talk about some important topics that we face in everyday practice. Us as internal medicine, endocrinologists, diabetologists, as well as in the obstetric department, which is the thyroid functions and the problems that we face during pregnancy. So I would like to let you know about my lecture highlights. What are we going to talk today about is the complication of the deranged thyroid function test during pregnancy, some physiology and the interpretations of the thyroid function test and why the problems happens. What are the tests that are important to be done during pregnancy? And how do we interpret these tests in view of other problems the patient having during the period of the test? Of course, the most two important conditions are the hypothyroidism and the hyperthyroidism in pregnancy, and some clinical scenarios in relation to these two problems. So, complications of the deranged thyroid function test. Is it important? It is definitely very important in pregnancy, and not only for the mother as well as for the child, the fetus as well. So the problem, if there is a problem in the thyroid during pregnancy, it may lead to preterm delivery. It may lead to low birth weight infants. It may lead to miscarriages, gestational hypertension, and stillbirth. So as we can see, it can affect both mother as well as the fetus. So it's an interdisciplinary teamwork between many specialties to provide a better outcome of the pregnancy for both mother and the baby. So why there is a problem in the thyroid function test during pregnancy? As we know, the physiology of pregnancy is having many aspects because it's a hyperdynamic circulation and related issue. So what we can see is that there will be an increase in the renal iodine excretion. And as we know, iodine is a very important factor for the manufacturing of the thyroid hormones. there will be an increase in the thyroxine binding proteins, which is the thyroglobulin, that is the carrier protein of the thyroid in our circulatory system. There is increase in total T4. There is an increase in the thyroid hormone production, and that is because of the hyperdynamic circulation, and there is the stimulatory effect of the HCG on the receptors of the TSH, so which will lead to thyroid hyperstimulation and change in the hormone concentration. So in a normal pregnancy, we will see low TSH, and that is a result from the stimulation of the beta HCG unit to the TSH receptors. So they will bind instead of the TSH to the receptors, resulting in a lower level of TSH. For this reason, the thyroid hormones, T3, T4, might be elevated a bit in the early pregnancy. So, the accurate assessment of the thyroid function test is at all stages of pregnancy is very important for if we want to see whether the patient having a real genuine problem or there is a disease in the thyroid that need to be managed during this pregnancy for the better outcome of both, as we said, mother and baby. So what are the tests that we need to be doing? The first and the most important test that we all do in any initial thyroid assessment is the TSH. This is the most crucial, and according to its reading, we can judge the other tests that need to be done or not. This is usually done at the booking visits as early as possible in any first time that the obstetrics see the pregnant lady. And of course, if the lady already having an existing thyroid problem, then this is the job of the internal medicine and endocrine to advise that this test should be done as early as you get pregnant. Then we will have the free T4, free T3, and then the total T4 and T3, which are protein bound. And then we will have to measure the thyroid antibodies, mainly the anti-thyroid peroxidase antibody. This is one of the most important tests that need to be tested if there is a problem in the thyroid function test. There is an important consideration in the interpretations. We need to consider it in testing the thyroid function test, which is the pregnancy trimester, because there are different readings for the levels of the hormones in a few points of an amount in different trimesters, from the first, second, and the third. So this is a very important to know how many weeks is the lady pregnant. And then whether there is a pre-existing thyroid problem before she gets pregnant, whether hypo or hyperthyroidism, whether this pre-existing thyroid problem is related to thyroiditis, which is associated with positive antibody or no, and if the patient is taking other medication which affect the thyroid function test. As we know, replacement with thyroxine or other thyroid medication that are given for hypo or hyperthyroidism has so many drug interaction and linked to their activity and absorption inside the body. So what are the drugs that interfere with the thyroid function test? There are different drugs. Some of them are not used during pregnancy, but I'm highlighting here in my lecture some of the important drugs that commonly used in a daily practice, and we may not be aware from it, but they are already being used by the pregnant lady, and they may affect the thyroid function test interpretation. For instance, iodine, lithium, and dopamine antagonists, cimetidine and sulfonylureas, increases TSH level. Okay, and glucocorticoids, propranolol, amiodarone, and propylthiouracil inhibit T3 and T4 conversion. So they will affect the reading of the free T3 and free T4. On the other hand, glucocorticoid, dopamine agonist, and somatostatins decreases TSH level. Phenytoin, sulfonylureas, diazepam, furosemide, and salicylate inhibit T4 and T3 binding to transport proteins. Cholestyramine, ferrous sulfate is one of the common drugs used during pregnancy due to anemia. Aluminum hydroxide is also an antacid, and surfactants as antacid. They are common, can be used during pregnancy. They inhibit gastrointestinal absorption of the thyroid hormones if we are trying to replace the lady with thyroxine. As we mentioned, some of them are not usually used in pregnancy, but it's been mentioned due to their interference generally with the thyroid function test. So we will come to the most common problems that we encounter is the hypothyroidism. It is seen in about 2.5% of the pregnancies, okay, and it is presented by lab with high TSH level and low free T3 and T4. As we said, if the patient is already hypothyroid, and then controlling the thyroid function test is having a better outcome for both mother and the baby. So when we find a high TSH, there are many things we need to understand. Whether this patient is already having a pre-existing hypothyroid problem before getting pregnant, whether this hypothyroid is controlled, whether there is antibody associated and leading to the thyroid disorder, if the lady was having subclinical hypothyroidism before she gets into pregnancy, and whether we have antibodies or no. So these considerations are very important, but ultimately all of them will lead to one conclusion, which is the proper control of the thyroid function test. We are aiming to keep the TSH level as a general rule to be below 2.5. This will have a better outcome of the pregnancy. And the free T4 is between 16 to 21. These two readings for the total TSH, for the TSH level, and the free T4 can vary by small amount in between first, second, and third trimester. But that's why the general rule is to keep the level, whatever the pregnancy age is, between these two readings for these two tests. That will give us the better outcome of the pregnancy and will prevent the complication that is mentioned earlier. So the presence of the antibodies and the control of the thyroid problem, even for hyperthyroidism, will be the same figures almost. So this is the general rule that we need to keep in our mind. So how we will achieve this target? So as we said, once the lady is pregnant, TSH level should be done at booking, and if she's already having pre-existing hypothyroidism before pregnancy, so that will make us think of more tight control during the pregnancy. Is that in a general rule, and due to the physiology that we have mentioned earlier and the changes in the TSH stimulatory effect of the HCG, so the dose of the thyroxine should be increased by 25 microgram or 20 to 30% of the dose that the patient already owned before getting pregnant. And then we have to repeat the TSH every 4 weeks, optimally in pregnancy. But if we change the dose and we feel there are some symptoms that the patient give when we examine and we take the history is guiding us to an uncontrolled condition, then we might repeat it as a low as 2 weeks after changing the medication. So this all depends on how tight is the control and what is the level of TSH at the initial test when the patient is pregnant. Why we don't test it very frequent? Of course, all of us, we know that the thyroid hormone is a long acting inside our circulation, and that the level will not change in a day or two. So I'll give you 2 cases here, just a general discussion about the idea of the case. Is a 36-year-old lady. She's 12-week pregnant. She has hypothyroidism since 4 years. So already we know that this lady coming to be having a pre-existing thyroid condition at the day that she came for us for the obstetric clinic for the booking. So she takes 50 microgram of thyroxine every day. And her initial TSH was 3. Free T4 is 17. And you can see in between the bracket the reference range for the trimester. And free T3 is 5. So almost T4 and T3 are in a good range, while TSH is on the upper limit of the normal. Her thyroid antibody is negative, so she's not a case of thyroiditis. So in this case, if she came at 12 weeks, this level of TSH is not bad in view of the negative antibody. But if this lady was having positive antibody, then we might consider increasing the thyroxine dose. And for case 2, she's a 25-year-old. She is in her early pregnancy, only 8-week pregnant. She has a history of 1 abortion. And her TSH is 4.1. So the limit is 0.1 to 3. So it's already above the limit required for the first trimester. T4 is 12. So it's on just below the normal, and T3 is 3. Okay. And for these 2 abnormalities, we have requested the thyroid antibodies, okay, and it found to be positive. So there are so many studies suggesting increased risk of pregnancy complication with the presence of antibodies, especially anti-TPO antibodies. So this lady at 8 weeks, and she came to us for first visit, definitely we should start her on a small dose of thyroxine to bring this level to 3 or even below 2.5 and normalize this one. And we will repeat the TSH in 4 weeks. So subclinical hypothyroidism, if the patient have it before getting pregnant, or it was diagnosed in early pregnancy with negative antibody, we need to follow it up. If there is no clinical signs of hypothyroidism like bradycardia or weight gain or other related presentation. But if it was with positive antibody, as the patient we had earlier, it should be treated, especially if this patient having a history of abortion or raising TSH, or there are other risks like it's many other issues that interfere, all the age of the patient and late in getting married or whatever the other risk that we assess from obstetrical point of view. So a clinical and pre-existing hypothyroidism need to be maintained, the TSH level within the desired range, and preferably, as we said, less than 2.5. That is the ideal. Keeping it as near as this figure will give always a better outcome. Now we will come to discuss about hyperthyroidism in pregnancy. It is less common than hypothyroidism. It is seen in a small percentage of pregnant lady. And of course, all of us, we know hyperthyroidism is a thyrotoxicosis because of its hypermetabolism and hyperactivity stage. So the most common and frequently encountered in the daily practice clinic is the Graves' disease, and it is seen before pregnancy in 0.14 to 1% of the women and approximately in less than 0.2% of the women in pregnancy. Other non-immune, this one is associated with antibodies, so this is non-immune related cause is toxic multinodular goiter and toxic anidones. So for the consideration of the interpretation of the thyroid function test in pregnancy, a very important clinical scenario that it may face a lot of the obstetrics during the early first trimester is the gestational transient hypertoxicosis. So why it is happening? This is during pregnancy and transient. It's for a short period of time, usually in the first half of the pregnancy. It can affect 1 to 3% of the pregnancy. It is characterized by low TSH and high T4, free T4 level due to the HCG stimulation of the TSH receptor, as we mentioned earlier in the physiology. And it is usually associated with hyperemesis gravidarum because usually hyperemesis gravidarum is seen in ladies who have a very high HCG level according to the gestational age. It can also be seen in molar pregnancy, multiple pregnancy as a common cause as well. And then there is no need for any medication, only fluid correction, rehydration with correction of electrolyte imbalance due to the vomiting and the nausea that the lady having is unable to eat or drink. So sometimes admission to the hospital with IV fluid and antiemetic is required. In severe cases, that is, the patient is hardly can be weaned from IV fluid due to the vomiting and anorexia that they are having. We can give a small dose of beta blocker, but it will only be required for a short period of time because it usually improves or regress as pregnancy age increases. So we'll talk about the most common hyperthyroidism problem in pregnancy, which is grave disease. And if the woman is known to be having hyperthyroid condition before she gets pregnant, then she is advised to be in an euthyroid phase before getting pregnant. And to achieve this, she should have at least 2 sets of a normal thyroid function test 1 month apart before she plans to get pregnant. Some of the literature say even we can advise some contraception pill for this lady to achieve being euthyroid before getting pregnant. And this is the general rule and consideration that should be advised by the internist and the endocrinologist before she gets pregnant. But what happens if she comes with us and she is pregnant? So antithyroid medication like carbimazole and PTU are found to have a teratogenic risks. Carbimazole is more clever than propylthyrouracil, and new literature also had seen that PTU have also a teratogenic risk. And if we can postpone the use of these medication up to the 16 weeks of gestation, that will be a preferred outcome for the baby and the mother. But sometimes if the patient is thyrotoxic and there is a flare-up during pregnancy, then we might need it to use at 16 weeks of gestation. And we can try before starting the antithyroid medication with beta blockers. And most commonly we use propranolol because this one will reduce the symptoms as well as peripheral conversion of free T3 to free T4, so it may ameliorate the presentation. The other treatment option for the thyrotoxicosis in general is radioactive iodine, and usually it's contraindicated in pregnancy. And if the woman was known to have thyrotoxicosis had used it, then she should not get pregnant for at least 6 months. And of course, the third option is the thyroidectomy. And this can be done in pregnancy for severely uncontrolled thyrotoxic female and who had failed medical management. So a very important slide, although it's a condensed one, but it is related to the effect of the antithyroid drug on the fetus itself. So we have to know that antithyroid drugs usually crosses the placenta, and antithyroid drug therapy for maternal hyperthyroidism also modulate fetal thyroid function because they crosses the placenta. So all antithyroid drugs tend to be more potent in the fetus than in the mother. So this is a very important line. We have to keep it in our mind. When the mother is made euthyroid, the fetus is often overtreated. For this reason, we need to avoid undesirable effect, and we need to aim to maintain the maternal total T4 and free T4 at normal or just above the pregnancy specific upper limit of the normal, to avoid over treating to prevent the effect on the fetus. So it's an equation in this condition. If we overtreat the mother to bring the TFT to the normal desirable level, the baby will be overstimulated. So that is the general rule. The smallest possible dose of antithyroid drug should be used whenever it is possible. Okay, so What are the signs of fetal hyperthyroidism? We know earlier that during the pregnancy, the antibody crosses the placenta. So ultimately, newborn, they may be at a risk of getting Graves' disease. So there are some radiological signs. Of course, this is the most easy and non-invasive tool that we can use for detection of the fetal hyperthyroidism, is that there will be a tachycardia with a pulse of more than 170 lasting more than 10 minutes by ultrasound. There will be an intrauterine growth restriction. There may be the presence of fetal goiter. That's why there comes the rules of fetal medicine and anomaly scan to detect this problem as early as possible in hyperthyroid pregnant lady. And there will be an accelerated bone maturation. So these are the effect of hyperthyroidism in the womb, inside the uterus on the baby. And last is the signs of congestive heart failure and hydrops fetalis. That mean that it's a very hyperdynamic circulation in the baby. So I'll come into two cases here. Case one is 30-year-old pregnant, 10 weeks of pregnancy. She has vomiting with dehydration. Her TSH is 0.1, so it's on the lower limit of the normal, and free T4 is 18. So it's within the normal or the upper limit, and free T3 is 3. So is this a case of genuine hyperthyroidism? No. This is a case of hyperemesis gravidarum. We need to follow this patient closely, okay, to exclude undiagnosed thyroid problem in the next few weeks and correct the vomiting and dehydration with electrolytes. The second case is a 25-year-old, 18-week pregnant. Her TSH is 0.2. Her free T4 is 20, so it's just above the normal. And free T3 is 6.5. Her thyroid antibody is negative. Okay, this is her initial test that's showing these problems. Then we came, because this is a case of early thyroid changes in pregnancy. So her antibodies is negative. Clinically, the patient pulse is normal. There is no sweating, no palpitation, no change in weight. Her weight gain during pregnancy is good. There is no vomiting, no anorexia, but it was detected by the gynecologist. Okay, so shall we give antithyroid? No. If we can, on repeating the TSH after 2 to 3 weeks, we found this one came lower. So in this case, to prevent the problem, a small dose of beta blocker we can give to ameliorate these readings, and we can repeat the test every 4 weeks. In the meantime, we have to instruct the patient at any time if she feels the hyperthyroid symptoms of sweating, palpitation, insomnia, feeling hot, then she should follow at earlier time to increase the dose of the beta blocker or antithyroid drugs. So to cut it short, I'll give you a few points. That TSH should be always checked at booking. I hope most of the female book as early as possible and start their investigation. Thyroid function test in detail will be done if the TSH found to be abnormal. Many factors affecting the level, and the most important is the trimester age. Maintaining euthyroid as much as possible is the goal of the treatment to have a better outcome of the whole pregnancy. I really thank you so much for your listening and for your time, and I'm happy to have any question if you have. Thank you so much.
Thank you so much, Dr. Sabri, for this wonderful lecture. We would now go ahead and take a couple of question answers from the audience. So the first question that I've received is, ma'am, there's no consensus on guidelines for women who are at low risk for screening thyroid diseases. What do you suggest here?
Actually, I believe that testing the TSH is one of the vital lab to be done at the booking, because there are so many hidden subclinical thyroid or problems, whether a hyper or hypo, which was not diagnosed and it turned to be overt in pregnancy. So I believe testing is a very important aspect.
Thank you so much, ma'am. Could you also help us understand why mild maternal hypothyroidism and the evidence regarding it being related to obstetric complications have several obstacles for a researcher in proving this relationship?
Because there are some complication, as we have highlighted in the lecture, which are documented and by ultrasonography, which is the least invasive procedure. And as we know, hyperthyroidism is a hyperdynamic state, and these are documented finding by sonography. That's why the fetal medicine has a very important role to be involved in the diagnosis. And there are so many variations in ethnicity for the liability to get thyroid problems. This has been seen in many literature, even in many guidelines as well, according to their geographical area that they came from, whether it's a mountain area, it's a sea area, which affect the iodine intake and many other factors as well.
Thank you so much, ma'am. One last question before we close. Now, a number of studies have shown differences in thyroid hormone concentrations based on ethnicity. You also talked about it in your previous answer. Could you help us understand this part better?
Yeah, actually, ethnicity is very important, because we know that people who live in mountain area in the normal setting, they might have some goiter issue. Goiter is enlargement of the thyroid gland. This is related to the iodine level in the water they drink in that area. So we call it physiological, which is not harmful. It is not associated with any hormonal changes. And by geographical distribution of us in the world, some Caucasian or Asian are more liable for thyroid problem than other aspects of the world. This is by our geographical distribution. There is no clue why it is happening like this, actually.
Thank you so much, ma'am. These are all the questions we had. I would like to thank you on behalf of DocPlexus for taking out time from your busy schedule and speaking to us on such a pressing issue. Also, dear audience, thank you so much for tuning in, and stay tuned for more such clinically rich sessions exclusively on DocPlexus. Until we see you again, please take care and have a great evening ahead. Thank you so much.